I'll be presenting the immunological biomarkers and histopathology in patients with this clinical phenotype of elevated IL-18, pulmonary alveolar proteinosis, and recurrent macrophage activation syndrome, which we've called IL-18 PAP-MAS. In comparison with other inflammatory diseases, lung diseases, especially shin-associated vasculopathy with onset in infancy, or SAVI, which we study more in depth in the lab. Most of the data that I present today was collected by Hanouf Al-Salim, a very talented pediatric rheumatologist during the time that she spent in our lab recently. And the this study has been led, is being led by Scott Canna and Rafaela Gobaknensky. So the IL-18 PAP-MAS phenotype was first described in this two recent publication from Grant Schuller and Vivian Thaper. And I have et al. And I have the privilege actually to be joining them here today for this session. In our study of patients with an interferon signature, we described these 8 patients with this phenotype. They all had recurrent macrophage activation syndrome, pulmonary alveolar proteinosis. They also had a sudden onset of clubbing, as shown here, and a minimal arthritis or no arthritis at all. In addition to that, they had very extremely high levels of IL-18. So these patients with IL-18 PAP-MAS, they have a typical serum cytokine signature in addition to the extremely elevated IL-18 levels. And this signature is very similar to the previously reported patients with gain of function mutations in NLRC4 by Scott Canna. So as you can see here, the serum IL-18 levels is very comparable to the NLRC4, which we call NLRC4 MAS. So given the important role of type 2 interferon or interferon gamma in macrophage activation syndrome pathology, we decided to use our 28 gene interferon score to check if some of those genes were also induced by not only by interferon alpha or type 1 interferon, but also by interferon gamma or type 2 interferon. So we found that these 9 of the 28 genes, they were also induced, they are induced by both alpha and gamma. And then we noticed that patients with IL-18 PAP-MAS have significantly higher, the contribution of these 9 genes to the 28 gene interferon score is significantly higher in the patients with IL-18 PAP-MAS in comparison with patients with the monogenic type 1 interferonopathies, Kendall and SAVI. So the objectives of this study that Hanouf did was to characterize the immunological biomarkers in serum and also in lung samples, which included BAL, bronchoalveolar lavage, and also lung biopsies in patients with IL-18 PAP-MAS in comparison with other inflammatory diseases. So we had a total of 8 patients enrolled in the NIH protocol. We had serum on 8 of them, RNA from whole blood in 8 of them, also for the nanostring assays, bronchoalveolar lavage in 2 patients, including the cell pellet from the bronchoalveolar lavage, and also the supernatant itself. And we had histopathology material from 3 patients with IH in PAP-MAS. And then the patients we used for comparison, it varied depending on the assay that we are comparing, but overall, it was patients, they were patients with NLRC4 MAS, patients with interferon-mediated disease, including 7 SAVI patients, patients with the IL-1-mediated disease, neonatal onset multisystem inflammatory disease, or NOMID, 4 patients, patients with sarcoidosis and healthy controls. The patients with sarcoidosis are followed by Dr. Joseph Fontana at the NIH. So the cytokines were measured by customized Luminex assay, both in serum and in BAL. We also quantify the levels, the RNA levels by Nanostring from the 28 genes. And our panel also include, it's not in the 28 gene score, but it includes CXCL9. So we also measure that. And we also score the lung biopsies with the help of our histopathologist at the NIH for inflammatory and damage filters. And we also score the damage and inflammatory manifestations in the chest CTs in an unbiased way by radiologists at the NIH. So the age of onset of these patients, these 8 patients in our study, they varied from 6 months old to 12 years old. And the lung disease onset varied from 15 months to 12 years old. All patients had clubbing, and IL-18 levels were extremely high in the patients, in all patients tested. Interestingly, 2 patients fulfilled, 2 of the 8 patients fulfilled criteria, ILAC criteria to systemic SJIA. The treatment response was variable to anti-IL-1 therapies in association with cyclosporine in some cases, and 1 patient received a JAK inhibitor in association with IL-18 binding protein. So this is the comparative data with SAVI. So in the lung chest CT, the disease are very different actually, both radiologically and also histopathology wise. So the patients with IL-18 PAPMAS, they have bilateral infiltrates that are usually predominantly in lower lobes. And also these patients specifically had the volume loss of the lung as well. In patients with SAVI, they have ground glass opacity and also emphysematous changes, as you can see here by these areas, which we don't see in these emphysematous changes in the patients with IH PAPMAS. So in terms of the radiology score, the inflammatory score of the chest CTs was higher in patients with IH PAPMAS in comparison with SAVI. And on the other hand, patients with SAVI had a higher damage score or fibrosis associated score or emphysematous changes than patients with IH PAPMAS. And in terms of biopsies, lung biopsies also, we reviewed these lung biopsies in many sessions, histopathology sessions, and then we noticed that they also have very distinguished histopathology. We have stainings, also specific immunostainings for these patients, but represented here is just the main features of the patients with IH PAPMAS, which are type 2 pneumocyte hyperplasia, which we saw in all biopsies we reviewed. and as well as the accumulation of proteinaceous material, which characterize these proteinosis, alveolar proteinosis, and with formation of cholesterol clefts. In SAVI, all patients, they have a accumulation of lymphoid follicles within the in the interstitial perialveolar area. So these follicles are mainly there are many B cells infiltrating here, but there are also T cells infiltrating, but it's a predominancy of T cells. And the main, and besides that, we also see a lot of emphysema changes in SAVI, which can compromise up to 90% of the lung area in the biopsies that we reviewed. And the feature that we are trying to understand better now in collaboration with Manfred Baum's lab in SJIA is the fibrosis present in SAVI. It's fibrosis, very remarkable. If we have staining.
Adriana, 1 more minute, sorry to interrupt. 1 more minute.
Sure. With perivascular fibrosis, not only in large vessels, but also in small vessels. And then for the inflammatory, for the same biopsies, we score these biopsies for inflammatory findings and for damage. And overall, we see that the emphysema, that patients with SAVI, they have a higher, they have more emphysematous changes, less consolidations than patients with IH impact mass. IH impact mass don't have the fibrosis that's prominent in SAVI, and both perivascular and peribronchial. And but on the other hand, they have more inflammatory findings like the type 2 pneumocyte hyperplasia. In terms of the cells infiltrating the lungs, both diseases have alveolar macrophages increase quantities of alveolar macrophage in comparison with healthy controls, but in IH impact mass it's higher than in SAVI, and also the frequency of neutrophils, so innate immune cells mainly. So I'm going to just briefly show also the cytokine studies that were done by Scott Kenna. In the serum, the patients with IH impact mass, of course, have extremely high IH levels in comparison, even higher than patients with NLRC4 MAS. And also in the whole blood nanostring, we've used this ratio between CXCL9, type 2 interferon gamma inducible cytokine mainly, and CXCL10 ratio. And we noticed that in these patients with IH impact mass have a higher ratio than patients with SAVI. In the BAL, Scott also measured IL-18s extremely high in the 2 patients tested in comparison with the other inflammatory diseases. And CXCL10 is also high, 9, sorry, is higher than in sarcoidosis, but not than in SAVI. However, we also tested this ratio in the BAL, and these patients have a higher ratio than SAVI, but in sarcoidosis is also high, actually. And finally, sorry, I'm a little late. Finally, we also did some correlations between the serum interferon gamma and our nanostring scores and gene counts. Due to the small number of samples, we didn't reach significance for the correlations, but I just wanted to show the trend that we have. So we have a positive correlation between the serum interferon gamma and type 2 interferon score, which is expected. But and then we have also a correlation between the interferon alpha 2 type 1 interferon and the type 1 interferon score, but we have a negative correlation between this interferon gamma in the serum and the type 1 interferon score, which is very interesting as well. And this one is the most striking because there is a negative correlation between serum interferon gamma and the nanostring counts of in the whole blood for interferon gamma, suggesting that the interferon gamma in the serum is coming from somewhere else other than the blood, mostly from somewhere else. For example, could be the lung cells. So in conclusion, IoT papillomavirus is this recently characterized disease, which is not yet genetically defined. The histological features are very different between, and radiological features are very different between the two diseases, IoT papillomavirus and SAVI. And the high level of free IoT, which I didn't point out, I should, very high levels of free IoT in BAL suggests that this cytokine in this specific pathogenesis, the role of this cytokine, the specific pathogenesis of pulmonary alveolar proteinosis. And then I wanted to thank Rafaela Gobakmeski and Scott Kana, who led this study. And again, Hanouf collected all this data and the other collaborators as well. Thank you very much for your attention. Sorry, I was over time.
No worries, thank you.
Adriana, thank you very much. That was a really interesting presentation. I do want to move on so we stay in time, but I think I'd like to ask two quick clarifying questions. The first is, did any of these patients receive either anti-IL-1 or anti-IL-6 before the onset of lung disease?
Before the onset, no. I don't believe so. At least for the 8 patients, I don't believe. No, I don't believe so. Mm-mm.
Did any of the patients respond in their lung disease to JAK inhibitors?
Yeah, we had only one patient with who received a JAK inhibitor. I think we cannot say that yeah, there was a response specifically of the lung disease, because it was in combination also with anti-IL-1 therapy and also with a IL-18 binding protein. So, but maybe others who are much more familiar here with the case, the patient can also comment on that. But yes, I don't think so.
Finally, we know that there's a prominent subset of patients with systemic JIA, or at least we call that, who have no arthritis. So is there any reason to say that these patients just aren't that subset? These aren't just straightforward systemics, because they sort of look like systemics without arthritis, which is very common.
Yeah.
Is there any reason to think that they're not just straightforward systemics, or the systemics are this?
Mm-hmm. So I think, so only 2 patients of those 8 at least fulfilled criteria for SJIA, but I'm sure that others here are much more qualified to discuss that than myself, maybe Grant or Alexi, Scott. Yeah, they can say what they think, but yeah, we have we believe they don't have a systemic JIA, but I think others could also give stronger arguments than myself, for sure.